Thank you very much for inviting me to be a part of your webinar. And I'm happy to share with you some of my experiences with the management of malpositioned lenses. I will come back to the presentation. So basically, there are different reasons for explantation of monofocal IOLs. Some of them is a loss of transparency, and some are related to dislocation and decentration. And one of the reasons could be incorrect lens power that happens in many cases. As already mentioned by Dr. Iol, optical aberrations and blurry visions in more than 60% is the reason for multifocal IOL implantation. But sometimes it happens because of the incorrect lens power, and some power adjustment can be done either by exchange or by some other methods. Basically, there are different lenses. All of them we do have in the market. All of them can be dislocated. However, most probably the single piece hydrophobic acrylic with haptics is the most predominantly used, and that's why they dislocate more than other types of lenses. So it's quite specific to the market of the lens. So there are early dislocations that happen usually because of complicated cataract surgery as a result of asymmetric IOL fixation and improper position of the lens in the capsular bag. Some of the cases are the result of incomplete or torn capsulorhexis. So this is the case one, early IOL explantation. This is the Lentis M Plus IOL, and the patient was complaining on visual acuity fluctuations, blurred vision during the day, red eye. IOP was increased. However, it was controlled by instillations of hypertensive medications and carbonic anhydrase inhibitors, systemic, but still IOP was not perfect. Vision was quite good with substantial cylinder, not corresponding to the astigmatism of the cornea. So this is how the eye looked like. You see there is a lot of pigment on the anterior surface of the iris. We also can see the pigment incarcerating the paracentesis. So it's a significant pigment dispersion syndrome, and we see accumulation of the pigment in the anterior chamber angle, in the trabecular meshwork, showing us that there is something quite wrong. And on mydriasis, we can see the edge of that lens, which is not very well centered and dislocated because it is not fixated inside the capsular bag. So what should we do here? Obviously, we need to explant this lens and consider exchanging it, because the reason for this dislocation was the problem with capsulorhexis, which was having radial tear. So that's why it was not reasonable to keep that type of lens, which is single piece, without haptical elements, or the haptical elements are not really designed for another types of fixation rather than in the capsular bag. So we cut the lens into two pieces, and the lens was removed from the eye with the help of the forceps. And the question is what type of lens we should implant, and the decision here was to implant the three-piece IOL, which is specifically designed for sulcus fixation. This is the Human Optics Sulcoflex lens. I don't have any financial interest in that, and it's having highly elongated optical elements as shown here, and allows the lens to position very reliably in the sulcus, and the diameter of the lens is 14 millimeters. And at the end of the surgery, we decided to place the leaflets of the anterior capsule on top of the optics, so to additionally avoid possible contact in between the optical edge and the iris. So you see these two areas where the capsulorhexis was teared radially, which was resulting in lens dislocation, and this new lens sits very well in the capsular bag. So this is another clinical case, probably uneventful phacoemulsification, performed 4 years earlier. Vision was quite good at the very beginning. However, 6 months later, there were several episodes of decreased and blurring vision, following with spontaneous improvement within 1 or 2 weeks, and IOP spikes that were treated with hypotensive and inflammation with non-steroidal anti-inflammatory topical drugs. So the patient is on systemic anticoagulants because of the artery thrombosis, pulmonary artery thrombosis several years ago. So this is how the eye looks like at one of the episodes of the blurry vision. And you see here, this is a drop of blood, and there is intensive red blood cells accumulation in the anterior chamber, presenting this significant Tyndall effect with decrease of vision and increase of IOP because of the trabecular meshwork clogging with the red blood cells. And on gonioscopy, we also see there is accumulation of the pigment resulting and the blood resulting from these episodes, as well as the blood that is also located in the vitreous body. We see there is substantial opacification of the vitreous body, which is quite homogeneous. So on UBM, we see that the lens optic is not perfectly well centered. We see that there is a center of the lens, and this is the center of the pupil. And again, we can see that the one optic of the lens is located inside the capsular bag, while the other one is going out of that area. And this is this area where the optic is located, not in the capsular bag, and we see these elements having contact with the iris, which is the result of bleeding. This is UGH syndrome, uveitis glaucoma hyphema syndrome, because of improper position of the lens with one optic element located in the capsular bag and the other one in the sulcus. So there are several options here. So we can exchange this lens with another one, or we can try open the bag and try to implant this optical element into the capsular bag. It's not so easy several years after the primary surgery, which was more than 5 years ago. However, some delicate maneuvers with viscodissection of the adhesions in between the anterior and posterior capsule allow you to place the lens properly, lens optic properly into the capsular bag, and to resolve this issue. And that is the case which was successfully ended. The IOL was located completely in the capsular bag, no high femur, and IOP was reasonably well controlled. This is UBM after the surgery, and we again see both optical elements are located properly. There is no contact in between the optical elements and posterior surface of the iris here and here, proving that there is no risk of any bleeding or hemorrhage as a result of that contact. There is another option that we may have is a late IOL dislocation, which usually happens when the IOL dislocates together with the capsular bag. It's usually combined with capsular phimosis, and sometimes we see asymmetric capsular contraction in these cases. But it happens usually 7 to 10 years following otherwise uneventful cataract surgery. Mean is about 8.5 years, published in the literature, and certain comorbidities are associated with that issue, which is pseudoexfoliative syndrome, glaucoma, and diabetes. And there are some publications that this IOL capsular bag complex dislocation might be a new epidemic for cataract surgeons, because we see more and more of these lenses that are dislocated. So this is a very typical case. We see that the patient was having glaucoma surgery. This is the site of the glaucoma procedure. And we see that the lens is well located inside the capsular bag. However, zonules are dissolved, and this bag is very unstable. So this is the case of the patient in his 80s, who was diagnosed with primary open-angle glaucoma, and combined surgery was done by IOL and glaucoma procedure with the subsequent EAC laser posterior capsulotomy, and there was a gradual decrease of the visual acuity, and IOP well controlled with medication. So what we see here, this is the edge of the IOL optic. This is the zonering rings. That is a proliferation of the epithelial cells, lens epithelial cells on the equator of the capsular bag. So we obviously need to correct this, and one of the options is to suture this IOL capsular bag complex to the iris, and this is the technique I use in these cases. I'm suturing through the capsular bag, around place the suture around the optical element, and then going out of the eye, and as shown here. And more or less the same maneuver is needed to be done with the opposite optical element. We need to stabilize the lens. We need to expose the area of the optics, because sometimes the pupil is not perfectly dilated. So you have issues in visualizing this area. So you need to place two sutures. I like to place these two sutures before tying the knots, because that helped me to center the capsular bag as shown here. And then by utilizing Sipser sliding knot suture, by externalizing the loop and suturing and tying the knot outside of the eye, and then pulling by the both ends of the suture, the knot is buried inside the anterior chamber. And as shown here, by tying these two sutures one by one, I really achieved good fixation. We see these two knots located here and here. There is a little bit of ovalization of the pupil, however, not very significant and not very cosmetically meaningful. So of course we have to be aware of the possibility of the pupil ovalization, and we need to avoid that as much as we can. So this couple of weeks after the surgery, the vision was still not perfect. However, the reason was that because of the ocular surface disease. So as soon as the ocular surface disease resolved, the vision was back to the preoperative values. What are the technical pearls for IOL explantation? Shown here, this is again asymmetric fibrosis of the capsule, and this is hydrophilic acrylic IOL located not in the capsular bag, but rather in the sulcus. I'm inspecting the capsular bag with the idea whether or not I will be able to reopen that bag and reimplant the optical elements. However, it was obvious that in that case, this is not a good possibility. So we need to exchange that lens, and this is cutting the lens. And don't forget to fixate the lens with a second instrument, because it's quite useful and help you to avoid rotation and help you to stabilize the implant while you are cutting it into two pieces, which is my preferred technique. We discussed that a little bit earlier with Bobby Osher's presentation. So I do actually like to have my incision wide up to 3 millimeters, and then remove these two pieces of the lens one by one, as shown here. This is done with plenty of cohesive viscoelastic located in the capsule, in the anterior chamber, to protect the capsule and to protect the corneal endothelium. And this is another clinical case with hydrophobic acrylic IOL, and again, it was not properly positioned in the capsular bag, and again, there was no possibility to reposition this lens inside the capsule. Here, the lens is repositioned into the anterior chamber. I sometimes stabilize the lens by externalizing one of the haptical elements. That helps me very much to additionally stabilize the lens. And as shown here, the proper intraocular scissors with these Packard-Chang scissors made by MST. I had no financial interest in that, and I love these scissors because they help me very much in solving these questions. So this is another clinical case. This is the IOL exchange, because this toric IOL was not properly powered. So it was an exchange of this one toric IOL versus another toric IOL. But this is another sharp pointed scissors, and you have to be quite careful, as I will show you later on here, when you're cutting the right final ends of the optics. You see here, I made a nick on the anterior capsule, and also I opened the posterior capsule with that instrument. So it was quite unfavorable situation here, because I need to reimplant the other toric IOL with the open capsule. That might be challenging. However, this case was completed quite successfully at the end, but I will not be showing it the whole case. So be sure that the tips of your instruments are rounded rather than sharp, and be sure that you have another instrument that you can introduce into the anterior chamber and stabilize the lens, which is also very important. So that's why in many cases, like in that one, I was implanting hydrophilic acrylic IOL, and suddenly I realized that both haptical elements were damaged. The upper haptical elements were damaged inside the injector. So there is no way I can leave this implant inside the capsular bag, because the position will not be stable. So this is pupil expansion ring, which is not a problem in that case, because you can place the IOL on top of the iris, and then, which is important here, rotate the lens and cut the lens close to the main incision. which allow you to prevent cutting the capsule on the distal end of that optical element. And then the procedure becomes more or less routine. You implant the next lens and you are done. 25 gauge vitrectomy is useful when the dislocation is associated with the vitreous going into the anterior chamber. So this is a 25 gauge port I introduced in order to have infusion, and you see that the left hand is stabilizing the implant, because with vitrectomy it can slide into the posterior chamber, and then you will having difficulties in catching it from the eye, and as shown here. So the lens is located completely on top of the iris. The pupil is a little bit constricted, and now it's time to cut the lens. So at that moment, it's better to decrease the infusion or even switch it off, because otherwise the iris may go out of the main incision, because the infusion from the posterior pole will lift the iris up and make the iris incarceration. So that's also another trick which is quite important to avoid a lot of excessive irrigation from the posterior pole in that case. And this is the hydrophilic acrylic with hydrophobic optical elements. Rigid PMMA lenses, and this is the case of combined surgery when the surgery was being done, explantation of the implantation of another lens, and a DSEC as shown here. So this is a PMMA lens. It's not easy to cut it, so I do prefer to remove these lenses as a whole, but you have to be sure that the lens will not stuck on the internal lip of the incision, which happened here. So you have to depress a little bit the incision in order to release this optical element to take it completely out of the eye. So we need to have a backup IOL in every case that we were discussing. So we can try to reimplant in the capsular bag. We can try to place the lens in the serious sulcus, iris fixated, iris suture, or scleral fixated lenses can be an option. How about outcomes of IOL exchange? So this is several studies shown here, quite substantial number of patients, 91, and surgical repositioning in the capsular bag. So there were we have to be prepared for quite a number of intraoperative and postoperative complications. You see that postoperative complications were 28.6%. So they are including from corneal pathology to retinal detachment. So this is a challenging surgery. So you have to be prepared. And in many of these cases, additional surgery was needed. In that case series, 14.3% of patients needed some extra manipulations. You have to let patients know in advance. So this is another quite a good case series where showing that one of the most common postoperative complications of that surgery was increase of IOP. So, and it was depending on the technique, IOL exchange to anterior chamber IOL, IOL exchange to posterior chamber IOL, or IOL repositioning, with the latter having probably less complications than first two, because in this case series it required much less manipulations. And this is probably the most the latest study, which is very important because it's randomized. So the patients were randomized into two groups, more or less equal in numbers, 54 and 50. In one group, there was an exchange of the dislocated capsular bag IOL complex to artisan IOL. And in the other one, it was repositioning with the scleral fixation. So basically, the results was very similar in two groups, with slight difference in complications, such as repositioning. For repositioning of the lens and suturing into the sclera, there were a little bit more bleedings, which is not surprising because we are passing the suture through the ciliary sulcus and sclera, while iris injury was more common for artisan implantation combined with the Iol exchange. So what is also important is that in substantial amount of cases, in 21% in the repositioning group and 26 in exchange group, 26%, the vision, 26 eyes, 11%. The vision was not better postoperatively than preoperatively. So you have to keep in mind that in about 10%, you may not improve the vision of the patient due to various reasons. And cystoid macular edema was more or less similar in both of these groups. So whether you're suturing the lens or fixating it to the iris, so there is no significant difference. So my take-home message is that IOL exchange is a challenging procedure with a high rate of complications, and not necessarily you will get the improvement of the vision in all of the patients. So we need to build the primary and well as the backup plan in case something will go wrong. In many cases, it's better to intervene early in order to be ahead of significant capsular fibrosis, and that will help you to reimplant the lens into the capsular bag. And refixation or exchange, it looks like they provide more or less similar results. And of course, you have to keep in mind that there are alternatives, alternative techniques, and lens models should be available. And I thank you very much for your kind attention.